Hedieh, I'm so happy to be chatting with you today. You and I both met as PhD students at University of Washington in 2021 when we were both in the same Arabic course. And here we are today talking as maternal health experts. Your career spans from early research roles in Paris, Boston, and at the Weiss Institute to global cancer policy at the U.S. National Cancer Institute and UICC, and now to leading WHO's global portfolio on quality and respectful maternal and newborn care. It's clear that you've built a career at the intersection of research, advocacy, and policy translation, always with a focus on improving people's lived experiences in health systems. Your insight on maternal and newborn health, respectful care, and evidence-based innovation are so valuable. Could you start by telling us what first motivated you to move from clinical and research settings into the broader world of maternal and child health policy?
Thanks, Larissa, and it's great to chat with you again and be reconnected. So I'm excited to answer some of your questions and sort of inform how we can improve global health and hopefully offer some insights. So I first started in sort of clinical lab-based practice work, thinking that I was going to work on improving health diseases. That was sort of the initial motivation. But then soon realized that my forte is actually in strong citizen and ambition is in sort of population level impact. So how can we actually move from really implementing interventions or understanding diseases at the global level to be able to make both global or community level impact, which is where really public health sits at, is really that sort of impact that's beyond sort of individual disease or day to day. And so I was really curious about sort of that higher level angle to health.
That's something that I relate to, and something some of the other people I've interviewed said the same thing about the trajectories to prevention, to larger scale impact. Yeah. So my next question for you, I have several questions ahead, so we'll move forward. Your work has taken you from Boston and Paris to Geneva, Beirut, and beyond. How have these international experiences influenced your perspective on health equity?
Thanks. I think each setting and each experience offers its own unique sort of perspective because every setting is different and every setting has its own context specific issues. Yet at the same time, you also see similarities where you have inequities in terms of those experiencing certain types of care versus those who aren't. And there are, vulnerabilities in terms of who is actually experiencing care. And so, for example, things like doing research, we looked at some of, our factors in terms of what's influencing respectful maternal and newborn care, which we'll talk later on, is things like sociodemographic, obstetric history. So those types of things that have affected individuals' experiences. In the US, we know that Black women, for example, are more at risk of having complications or poor respectful care, whereas in other settings, like in Africa and countries in Africa, it's, for example, being an adolescent, you're more vulnerable to have poor respectful care or being unmarried. And so I think there are these unique factors that sort of shape how health is in some ways behaviorally present in these different settings that each have its own challenges that need to be addressed.
Yeah. At WHO, you co-led the profile on quality of care and respectful maternal and newborn care. What does respectful care really mean in practice, and why is it vital for survival outcomes?
Thanks. So respectful care, and I'll say quality of care, has been really one of the forefront leading areas in sort of public health today. So since about 2018, there's been sort of three main reports that came out on quality of care, which was from the Lancet Commission, which was from the National Academy of Medicine, and also a WHO and World Bank report that all emphasize sort of like we need to move away from just health outcomes at all, not move away, but keep that we're improving on health outcomes, but clearly quality of care is is not being delivered well. And so in terms of maternal health, we saw that we're seeing increase in facility-based childbirths. So we knew that women were attending, but there were clearly other issues underlying the underlying sort of quality of care. And so this shift started coming into play. And then we had the WHO vision for quality of care, which was really around how do you place experience of care and provision of care at the center of care that is sort of safe and responsive to women's needs. So respectful care by our definition of sort of what we have led with the compendium that just came out in August is really an umbrella term for describing care that is person-centered. So making sure that women and families and individuals and their newborn at the forefront of care that is both safe, responsive to their needs, and complexities of their experiences, because each individual goes through different experiences, and how can we make sure that these individuals are placed at the center. So that's sort of how we defined it in terms of what it is in terms of how you can deliver quality of care, respectful care to women. And then in practice, really tailoring interventions. So how can we, for example, provide good communication between providers and women? That means, for example, asking them for consent for procedures, informing them and explaining to them what certain procedures mean in practice. Other things like, for example, preferred birthing positions. If women have certain birthing positions, what could that look like? And really sort of making sure their informed choices and autonomy is part of the discussion and not just sort of provider-led interventions.
Yeah, a lot of what I'm hearing you say is like based on the principle that we want more women to give birth in hospitals to reduce the risks of especially people being in rural areas or too far from healthcare in case of emergency, especially in areas that might be underserved or might need medications, for example, for postpartum hemorrhage or other issues. And so to get them to go into facilities, they need to be comfortable there.
And also not to dissuade them if they're coming to a health facility and being, for example, we've seen data from our study that was published in 2019, women are being slapped in health facilities, they were verbally abused. So also not to dissuade them from attending and going to healthcare facilities to deliver, because at the end of the day, we need to make sure that women have safe, and women and gender diverse people delivering have safe and responsive environments. It's a critical for so many women and people. It's a really critical time in terms of a turning point when you are sort of entering motherhood, and childbirth might be, an experience that you don't really have the how do you say this, you don't know what to expect. You might have been reading it, but your own experience it becomes so unique and life-changing. And so how do you really ensure that your voice is heard in those moments and isn't sort of crowded by sort of just a provider-led discussion? And we've also seen that providers also face burnout in other settings. And so it's really this balance of like, how do we just create a supportive environment for everyone at the healthcare facility?
Yeah, that might be answering partially the next question, which is what have you learned from WHO's Global Guide and Compendium on respectful care that surprised you? Maybe these were some things that were surprising, or were you already aware?
Yeah, some of the things that were surprising, I think, was, so we're leading this, like big implementation guidance that sort of is bringing together research from over the past like decade. It's bringing together terminology, it's bringing together and consolidating the evidence. And I think where we are now and what still surprises me is that we have measured this phenomenon. We know that this is happening in different settings across the world, whether it's across the world, even including in the US. We know that these issues are happening, but we actually have very little interventions and implementation efforts to actually support and testing and trying sort of what actually will work in these settings. And I think with my background in implementation science, sort of how do we now we did a series of systematic reviews looking at sort of what interventions are available. And we had to even go beyond maternity care to see sort of from the broader sexual and reproductive health gamut, like how can we bring together interventions that could potentially improve this phenomenon. But the thing is that they haven't been tested for respectful care. They haven't been tried, and we know that it's not one size fits all. So these sets of interventions that we're calling promising interventions in the compendium are really supposed to be areas where, okay, please test these now and try these in your setting to see what will work. And it's not like if this works in X setting, it will, automatically be something that will work in Y or Z. They're all context specific, but I think there's a lot of cross-country learning, cross-state learning that we still need to do in this area because the documentation has been there, but very little implementation and sort of learning to be done still.
We're really moving right in line with the questions because the next one is, in your research on mistreatment of women during childbirth, what are the most urgent system level reforms? I think you already knew the question that countries should be prioritizing.
Yeah, so I'll give you one example, and this is, again, I'm just trying to be sort of like stating the evidence in terms of like where we are. And there was a study that was done in 3 countries, in Lebanon, Syria, and Egypt, looking at sort of implementation of labor companionship. So labor companionship is also sort of an area of respectful care where a woman or individual should be allowed to have a companion of their choice as part of labor, childbirth, and sort of the postnatal period to support them as part of that. And we saw, and we still see, there's been scoping reviews looking at studies across the world that there are no policies, for example, in health facilities to even support having a labor companion as part of their experiences, which is really a low-hanging fruit from our perspective of just allowing a companion of a woman or individual's choice to be part of that. And I think that's sort of where that's such an easy sort of thing to be able to grapple with. Or another even area is sort of like health in terms of health systems is we're seeing that as part of this, women want privacy. There are, vaginal examinations. There are discussions that are private, that are just privy between the healthcare provider and women. And in many settings, there are no curtains, for example, or even if they're there, they're not being used. So how can we sort of improve the health systems to just implement a minor thing like a curtain to be able to be sort of improve that woman's sort of privacy and confidentiality experience while she's at the healthcare facility. And so I think those are sort of 2 areas where I see that it's low-hanging fruit that we can improve on at the moment. And we're still not there, even though the evidence shows that, they need to be done.
Still not there, and in some ways it seems so basic. I love conversations about aspects like this of health because I think there can be misconceptions that health is just inventing a medicine and giving it to someone. But there's so many things, like in my own work on postpartum hemorrhage, looking at all the reasons why that medicine might not get to the woman, even though it's available, we know it's effective, it will save their life. And other things like not having a privacy curtain, being able to have someone with you. These seem like such small changes that can make all the difference in the world. And so I love that public health encompasses all of these things: global health, public health, and just thinking about the whole person and holistic needs.
And I think the other thing is like really the measurement aspect of, for example, if I am saying that, okay, I didn't have privacy, I didn't have a labor companion. And then, sometimes there are also these surveys of, were you satisfied with your healthcare facility? And, we've seen that women are actually selecting, yes, I was fully satisfied with my care experience because they're relating that to, okay, my baby was alive, I left the healthcare facility and but then all these things happened to me as well. And so it's really the satisfaction, it seems to us, at least from a measurement even perspective, that it's not even working to ask women just that general question, but more really focusing on their experiences so that we can then have that evidence, that person-centered care evidence to take back to improve on these sort of basic things that that are not there, and then improve it across the whole health facility or system.
Wow, so many things you're saying remind me of, I mean, we're obviously have a lot of crossover, but in my dissertation, I did interviews with Ukrainian refugees, asking them questions about healthcare access. But then what I actually wrote about after these surveys and interviews was the way that in follow-up interviews, I asked people how they interpreted questions and why they answered in sort of idiosyncratic ways that I, as the researcher, was really not expecting. And yeah, I think asking the right questions and realizing that sometimes what indicators or metrics show don't tell a whole story is like really important.
Absolutely, absolutely. It really shows you sort of how it differs, right? I mean, in terms of like what they're saying versus what's really happening, rather than just, okay, are you satisfied with your experience? Just and really digging into that and making
Yeah.
sure.
And for someone that means, is their baby alive?
Yeah, yeah.
And I mean, that's important, that's critical, but okay, well, next question. You've worked across both technical evidence generation and global policy guidance. How do you ensure that lived experiences, such as those of women giving birth, are translated into policy at the global level? This is important. We talk about all these things, but how do we action them?
Yeah, so I think so I'm just taking the compendium's experience now as part of sort of where we are. And now we've done a few webinars, and sort of what the next crossover looks like is really engaging with those champions in countries on the ground to now try, like, I mean, go through this sort of process, our implementation chapter of like, okay, where are we at in terms of respectful care in your setting? Is it measurement? Is it you need now interventions? You've tried something, it hasn't worked. How can we sort of like move forward? And so it's really that sort of dependent on sort of the champion on the ground to move forward. I'll give you a successful example. In Guinea, we published our results. So we did I've been coding it, but we published this multi-country study on how women are treated during childbirth, our landmark WHO study that was published in 2019 in Ghana, Guinea, and Nigeria. And we in Guinea, once the study results were published, the lead author from the study site organized an entire 2-day sort of let's look into the results workshop, and sort of looking at what the results are showing in country and how we can now sort of implement things. There were no labor companions, there was no privacy measures. And so really taking accountability for each facility leader to sort of come up with solutions to be able to act on the data. And so I think it's really taking stock of what each facility or each country has in terms of this. And we're seeing movements with sort of primary healthcare being prioritized now, and sort of these movements that are prioritizing these issues. And so I think it needs to but we still have so much work to do. And I think even the measurement aspect, we still haven't fully integrated patient experience type questions and sort of these indicators that you were mentioning. We still aren't, I think, fully there. And I think it needs a huge investment to still be able to do that.
Yeah. Well, the next question, thank you for all that important information, is about silos. Maternal and newborn care is often siloed from other programs. How can countries better integrate quality of care, respectful practices into broader health system strengthening? Or you can speak to silos in global health in general.
That's a great point. I think, unfortunately, due to how the funding has been organized over the past couple of years, it's mostly been siloed funding, and we need to sort of, I think about how they can be integrated. So with respectful care also, we often get the question, oh, are you proposing respectful care completely separate to maternal care? And we're like, no, this is part of the grander maternal health sort of like program. And then we get the question, okay, so if that is also a part of the greater maternal health program, what does it mean for sexual and reproductive health? And I think there we're starting to talk about it. We're starting to talk about, for example, how does these principles sort of integrate across the grander sort of sexual and reproductive health topic, sort of the life, and then go even bigger and say life force really. So how do we really start to talk about these concepts universally across these different areas? And I think the issue, some of the silos is really the evidence base. Like even in maternal health, I can't speak to postnatal care, the respectful care and postnatal care period, because we don't have that much evidence to support, for example, what does respectful care mean in the postnatal care period? There's little evidence to support that. It's hard for us to sort of come up with, we can come up with sort of what translates from childbirth, which is where most of the research has been done. But it's difficult to say fully like this works in that setting or this works in that area. And I think we need to sort of have consensus, start to talk about this, start to have more research investment in this area. And I think we're starting to, with the healthcare provider burnout, we're starting to have investment in research, including even sort of that life force perspective. So I think it's really how, and then also collaborating, I think we need sort of collaboration, cross discipline collaborations, generally in public health to be able to achieve some of our goals and not be siloed with just our area and learn from other areas. And I think when we were looking at the interventions, we were learning from, for example, like for verbal abuse, we were looking at interventions, like what kind of interventions. And actually, we were looking at aging studies because there are many studies that have been done in sort of like retirement homes, et cetera, looking at verbal abuse and sort of how it pans out in those settings. And we found that, oh, wow, interesting. So how can we learn from that? How can we sort of translate that into what could potentially be helpful in terms of what can be translated as improving, verbal abuse and decreasing verbal abuse in the maternity care setting. So really those cross-discipline collaborations and discussions, I think will help us all to learn from each other in different areas.
So true. And I liked what you said about that that there's a trend of healthcare providers going into research due to burnout. I think it's interesting to look at in general the way that some negative situations can create a positive. I think that's important to keep in mind as things shift and change, and to think about the ways we can come together, that we can further integrate, that we can be interdisciplinary. So some of the highlights I was hearing you say that I'd love for global health students to hear too.
Absolutely. It's not just the person experiencing the care received, but also the one providing the care, and really put, again, that global lens of it's everyone that's in.
Yeah.
Cool.
And next question for you, a different one. Thinking about fragile and conflict affected settings thinking about fragile and conflict affected settings where you've also had exposure, Lebanon, for example, what strategies have you seen succeed in protecting maternal and newborn survival despite system fragility?
That's a great question. So there's movement in this area on fragile conflict and setting areas. I actually, part of my dissertation was looking at we had done a study in Palestinian territories. And so looking at sort of how we measure mistreatment in those settings, but then actually like developing a scale for what it means to measure it in those settings. And really, I mean, for example, our tool is 60 items, and 60 items is a lot for settings that are sort of overburdened by other sort of needs, other pressing areas. And so how do you so we have this global evidence, which is the ambitious sort of agenda of how we can improve quality of care, how we can improve maternal care. And I think when it comes to complex settings, it's really about what can be the most feasible and most implementable. What is the biggest bang for your sort of buck, and really how can you, yeah, I think it's really about the question of feasibility, and how you can implement interventions yeah, that the main question would be around sort of the feasibility of those interventions in those areas.
And it also occurs to me, and this is applies to and is separate from system fragility and conflict, but about things being like feasible in terms of like cultural context, things fitting the context, whether it's a context of conflict or a context where there's major cultural difference from maybe the funders or those who are coming in to be somehow implementers or interventionists. So I think there's always a tailoring that needs to happen, and people interested in becoming public health practitioners should always think about that.
Yeah, absolutely. And I think the other thing that's a soft, I don't know how to say this, a soft skill, or I think doing global health and doing public health, I think public health in general, I would say, because if I am in, I don't know, Boston and I go to Seattle, it might be different. There might be different, there are different settings, there are different needs. And I think having humility is a huge sort of important skill set, humility, empathy, and really listening to sort of your stakeholders, listening to sort of what is needed is essential in terms of how we think about what we want to do. Because what the evidence might say, those who are involved might not agree. And so how do you bring in how do you then help improve? You can't just say, okay, no one's listening. Of course, because we have to listen to sort of the experts who are the ones on the ground and who know always. And so I think it's a career, it's a field, it's an area that we are so humble, it's so humbling to work in. And so bringing that sort of listening and humility uh, perspective, I think, and putting the individuals that are at risk of X, Y, and Z issues, putting them at the forefront of many of these things is where it's critical. And I think as part of, I'm just going to give the compendium as another example, but when developing it, we continuously engage with users. So the target audience is sort of those who are delivering, while managing maternal health programs in countries. And so we interview them, we involve them as part of developing this global document so that we ensure that their voices are heard and that we are integrating what's needed at sort of from a global perspective, but also from those who are actually conducting and doing respectful care maternal health programs, what can actually work. And so I think otherwise your work is, if there's no listening and no humility, I don't think you can be successful in this field as well.
Thank you.
The hard skill set that I wanted to end on is always having a toolbox, whether that's being interested in qualitative research, whether that's being a quantitative person and looking and doing biostatistics. And so having a hard skill set to be able to assist on studies or on understanding, I think. And I think now we're also looking at some user experience research and how sort of UX plays a role. And so I think having a hard skill set to be able to do that on top of the soft skill set will set you apart from others. Hope that's helpful.
Oh, yes. I mean, I completely agree with you. And it's funny how that question about conflict affected settings went right into the question about advice for students.
Yeah.
So that was the end of the interview. But do you have anything else you want to add for advice for people who want to get into this field? We heard from you great information about soft skills, humility, putting the people who are receiving the intervention at the forefront of decision making and input on that intervention. And then we heard about the hard skills, data analysis, quantitative, qualitative. That is great. Any other words about advice?
Experience. Gain as much as experience as you can.
Yes.
Whether that's a personal story was I was really interested in oncology when I first started sort of my journey in public health and also just health in general. I mean, I started volunteering and handing microphones at a global oncology conference, and then sort of, started to network, started to make connections, started to understand what was happening, was listening to the conferences, wasn't able to afford to go. And so, just to put yourself out there and to make sure that you're always learning. I think a huge skill set for anyone, I think in any field today with the advent of AI and everything that's happening is a huge skill will be how do we learn to learn? And I think learning anything, especially for public health, anything is like any discipline can be brought in to improve health outcomes. And so learning to learn, and I find myself a forever student because I think there's always so much to learn in terms of how we can improve public health, including communication skills. Not an engineer, so I don't think I'm going to go that far, but there's a role for everyone to play, I think.
Definitely. One of my favorite things about public health, just inherently interdisciplinary.
Exactly. And I think there's something for everyone and how you harness that skill and being passionate and being sort of not obsessed, but being really passionate about something to the point of like, okay, how improve this is critical.
Wow, that's a beautiful thing to end it on. I won't ask any more questions. Thank you so much for all your input and time. And I think this will be great to share with people to learn from.
Great.
Thank you, Hedieh.
Larissa, great to chat.